Welcome to The Debate, a program where we explore substantive issues through, well, thoughtful disagreement. Today, we're diving into a really critical area for healthcare professionals, the multifaceted world of diabetes mellitus pharmacology.
That's right, and the central question we're tackling is this. For type 2 diabetes patients who don't have established cardiovascular or renal issues, should their first drug therapy be mainly metformin alone, or should we be looking at early combination therapy, especially if their blood sugar is markedly high, to get those levels down faster?
Exactly. And my position is pretty straightforward. I believe metformin monotherapy remains the foundational, the best first-line treatment for the majority of these specific patients.
And while I absolutely see the established role for metformin, I'm going to advocate for a different initial approach. I think for a significant subset of these patients, starting with combination therapy is actually more advantageous, more proactive, especially when dealing with that marked hyperglycemia or when speed to target is really crucial. Our whole discussion today stems from a deep dive into the paper All Diabetes Mellitus DM Pharmacology 3.pdf by Mohammed Osama Elmisiry.
Right. So, laying out my position more fully. For most type 2 diabetes patients in this particular group, again, no established cardiovascular or renal problems, metformin monotherapy really is the optimal starting point. The source material is quite clear on this. It states, and I quote, "Metformin is recommended as the initial anti-hyperglycemic medication because of its durable efficacy in lowering A1C and negligible risk for hypoglycemia or weight gain. It's, explicitly called the first-line initial therapy for most patients without cardiovascular or kidney risk factors. This biguana, it offers really substantial clinical benefits. We're talking about lowering A1C by about 1 to 2%, which is significant. And it brings down fasting plasma glucose levels effectively. And the benefits go beyond just sugar control. It has strong cardiovascular CV benefits noted, and it's weight neutral or mild weight loss."
These are crucial general health points for our patients. The way we dose it, starting low at 500 or 850 milligrams once daily, then bumping it up by 500 milligrams weekly is tolerated, up to maybe 1,500 to 2,000 milligrams a day. It's a measured approach. This careful titration helps patients adjust, it maximizes tolerability, and lets clinicians really fine-tune the therapy while managing those potential GI side effects. It puts safety first and builds therapy systematically without sacrificing that core efficacy.
Okay. I absolutely understand and acknowledge the foundational arguments for metformin. Its efficacy, its safety profile, they're undeniable, no question. However, for a not insignificant group of patients, even without those established CV or renal comorbidities, I really do contend that starting with combination therapy offers a more advantageous path, a more proactive clinical approach. This is particularly true when we see marked hyperglycemia or if getting to the glycemic target quickly is a high priority. And, the source material itself hints at this nuance. It notes that even in the absence of metabolic decompensation, combination therapy is recommended as initial pharmacologic therapy for people with marked hyperglycemia, e.g., A1C more than 1.5% above target.
And it goes on to say, combination therapy can be considered in adults with type 2 diabetes at treatment initiation to shorten time to attainment of glycemic targets. So, relying only on metformin, even though it works, might mean a longer period where the patient's blood sugar isn't optimally controlled. For us as healthcare professionals, that delay translates into potential long-term consequences we should be trying to head off. Starting with a well-chosen combination lets us hit the hyperglycemia harder right from the beginning, leading to faster goal achievement. And selecting that second agent is key. The material stresses it should be based on the individual's priorities, preferences, comorbidities, and cost. This really opens the door for a tailored approach, optimizing treatment beyond just the A1C number. For instance, if weight is a major issue for the patient, adding the GLP-1 receptor agonist early could offer really significant weight loss, maybe 5 to 15%, plus valuable CV protection, even if that CV disease isn't clinically obvious yet. It's fundamentally about being, forward-thinking and preventative in how we manage these patients.
That concern about prolonged suboptimal control, it's certainly valid. And it brings us to a key point of divergence: efficacy versus the speed of reaching that glycemic target. From my clinical perspective, that 1 to 2% A1C drop you get with metformin alone is both substantial. It's often quite sufficient for initial control for a large number of patients. The slow titration, adding 500 milligrams weekly up to that 2,000 milligram max, lets patients hit their target within what I'd call a clinically reasonable time frame. We usually recheck the A1C at 3 months, right? That gives metformin plenty of time to show its full effect. And importantly, it minimizes those initial side effects. This kind of structured step-by-step approach, where we monitor fasting glucose, aiming under 130, and the 2-hour post-meal glucose under 180, it ensures patients are managed properly without immediately adding the complexity and potentially more side effects from multiple drugs. For clinicians, this strategy reduces the initial treatment burden on the patient, which, can be absolutely critical for adherence. It lets us carefully watch how the individual responds. It's a prudent, evidence-based way to start for most in this category, building a solid foundation before we think about escalating.
Okay, I appreciate the emphasis on starting simple, minimizing side effects. That makes sense. But I have to respectfully push back on the idea that this approach serves all patients equally well, particularly those folks with marked hyperglycemia, the ones with an A1C more than 1.5% above their target. In those cases, delaying full control by just titrating metformin over weeks or months, well, that could actually be detrimental. The source material explicitly recommends combination therapy as the initial treatment for these individuals, specifically to shorten time to attainment of targets. And this isn't just about hitting a number on a lab report. It's about mitigating real risk. Prolonged high blood sugar, even if it hasn't caused obvious heart or kidney disease yet, it contributes to endothelial dysfunction, oxidative stress, a pro-inflammatory state, basically all the precursors to micro and macrovascular complications.
Fair point.
As healthcare professionals, our goal isn't just to eventually get to target, but to get there efficiently, to try and prevent or at least slow down this sort of insidious progression. Getting those glucose levels down quickly with combination therapy can give a much more robust, immediate initial response. It offers a more protective early course for patients who are starting way behind the 8 ball with high A1Cs. This kind of proactive intervention might prevent that cascade of effects from sustained hyperglycemia, potentially lowering the patient's lifetime burden of complications.
The argument for managing things comprehensively, especially when you bring in related conditions like NFLD, it does raise a critical tension with a safety profile and that initial treatment burden for the patient. My perspective, though, is that holistic patient-centered care, right at the start, often means simplifying the regimen. We need to ensure adherence and identify any underlying issues first. The guidance that the choice of the second agent should be based on the individual's priorities, preferences, comorbidities, and cost. That typically comes into play when we need to intensify treatment after metformin alone hasn't quite done the job. In that initial phase, particularly without established CV or renal disease, focusing on metformin lets clinicians first really assess for other things messing with the A1C, like potential precipitants such as infection, ischemia, concomitant medications, or changes in eating or physical activity.
And crucially, it lets us explore medication adherence and barriers, things like side effects, cost, patient beliefs, preferences. This layered approach makes sure we address fundamental issues, solidify patient education, before we add the complexity of multiple drugs. A measured, stepwise strategy starting with metformin usually fosters better patient tolerance, understanding, and, importantly, long-term adherence to what's often a lifelong treatment plan. It's about building a solid, understandable foundation, not immediately throwing up a complex structure that might just overwhelm a newly diagnosed patient.
That's a compelling line of reasoning, building that foundation. But I'd argue the concept of holistic, patient-centered care can and perhaps should justify early combination therapy even without established CV or renal disease. It lets us move beyond just reacting. Let's take an example. A patient comes in, type 2 diabetes, significantly obese, and maybe non-alcoholic fatty liver disease, NAFLD, is suspected or known.
The source material highlights that obesity is the primary risk factor for NAFLD, which coexists in 70% of obesity 2DM patients. Now, pioglitazone is uniquely pointed out as the only agent with level A evidence for histological improvement in non-diabetic NASH. So in that clinical scenario, starting with metformin plus pioglitazone isn't just about glucose. It's proactively tackling a major comorbidity like fatty liver and improving insulin sensitivity across different tissues right from day one, even if there's no overt heart failure or fracture risk yet. That feels like truly holistic early intervention.
Okay.
Or similarly, think about a patient, maybe significant obesity again, strong family history of early heart disease, but no established CVD disease themselves yet. Bringing in a GLP-1 receptor agonist early addresses a key patient priority weight loss while also providing primary cardiovascular protection. This feels like preventative medicine, optimizing their overall metabolic health and quality of life rather than just waiting for comorbidities to become established before we consider that comprehensive care. It's about seeing the interconnected pathologies and intervening early for the best possible long-term benefit for our patients.
Okay, the argument for comprehensive management in specific cases is certainly thought-provoking, but we absolutely have to balance that with the safety profile and the initial treatment burden. And one of metformin's huge advantages, highlighted right there in our material, is its negligible risk for hypoglycemia. Bringing in extra agents early, especially some of the older classes like sulfonylureas, can significantly ramp up the risk of adverse events. Sulfonylureas, for example, yeah, they're cheap, they work, but they carry a high risk of hypoglycemia, particularly with glyburide, and especially in vulnerable folks, the elderly, people with kidney disease. Even with the newer agents, combination therapy just inherently means more pills, which we know is a barrier to long-term adherence. Plus, you increase the potential for drug-drug interactions, additive side effects. Starting with just one well-tolerated, safe agent like metformin simplifies things. For the patient, for the prescribing physician, it makes it much clearer if any side effects are happening, what's causing them, and it makes dose adjustments more straightforward. From a clinician standpoint, prioritizing safety and keeping that initial therapy simple can really boost long-term adherence and cut down on potential problems from taking too many medications, even if the second drug on its own has a decent safety profile.
While the concern about increased treatment burden and side effects is definitely important, I'd actually argue that a thoughtfully selected early combination can optimize the safety profile and maybe even reduce the long-term burden for patients. My argument for early combination isn't about just throwing in any second drug in there, especially not high-risk ones indiscriminately. It's focused on strategically combining agents that work well together, complementary mechanisms, and that have inherently good safety profiles. Think SGLT2 inhibitors or GLP-1 receptor agonists. Both of these classes, the material specifically notes, have no hypoglycemia risk when used alone or with metformin.
Right, that's true for those classes.
Exactly. And they don't just offer robust glucose control, they bring substantial extra benefits: weight loss, cardiovascular protection, renal protection. SGLT2 inhibitors, for example, are linked with weight loss, 2 to 4 kilograms, and definite cardiovascular benefits. They can lower blood pressure, improve kidney outcomes, reduce heart failure hospitalizations, even in patients who don't yet have overt CV or renal disease. So combining them early with metformin gives you broader metabolic improvement right from the start without that significant hypoglycemia risk. It addresses multiple aspects of type 2 diabetes pathophysiology from day one. This proactive approach, using carefully chosen agents, could actually reduce the future treatment burden by slowing disease progression and its complications. Ultimately, it might offer a more streamlined, comprehensive therapeutic strategy right from the beginning, which is, a crucial consideration for us managing these chronic conditions. This whole discussion really underscores the profound complexity of optimizing these drug therapies for type 2 diabetes, especially for healthcare professionals trying to make the best initial call for their patients. From my perspective, for most patients without those established cardiovascular or renal issues, metformin monotherapy really does remain the cornerstone. It's robust, it's evidence-based, supported by its proven efficacy, that durable A1C lowering, and crucially, the negligible risk of hypo or weight gain. The strength of its foundational role, alongside vital lifestyle changes, is just undeniable in that initial management pathway. It prioritizes safety, tolerability, and gives a clear incremental path towards effective glucose control.
However,
I still maintain that a more nuanced approach, one that integrates early combination therapy for specific patient profiles, particularly those with that marked hyperglycemia, or maybe other relevant issues like obesity and NAFLD, even without established cardiorenal disease, well, it offers substantial advantages. These proactive strategies can speed up getting to glycemic targets and provide broader metabolic benefits. We can leverage the diverse mechanisms of newer agents that also happen to have a low hypoglycemia risk. This approach allows for a more personalized, maybe even preventative path forward. It addresses the individual patient's unique needs and risks right from the get-go, potentially heading off future complications, which has to be a key consideration for any clinician focused on long-term patient well-being.
Yeah, ultimately, I think both our perspectives really highlight the critical need for individualized care plans. We have to carefully leverage the rich and frankly evolving evidence within source materials like the one we discussed to inform our clinical decisions. The decision-making process for type 2 diabetes just has to stay dynamic. We're constantly balancing efficacy, safety, what the patient prefers, and that ever-present goal of optimizing long-term outcomes.
Absolutely. It really brings into focus how T2DM management has shifted. What might have seemed like a fairly linear path before now has these complex branching points, demanding more personalized judgment calls from clinicians. There's clearly a lot more to unpack within this comprehensive material.